So again, you have two major choices. You're a young person, you have no comorbidity, azithromycin. Okay? But imagine that you're a young person and you have cerebral palsy and you are in a nursing home. Azithromycin alone is not going to do it, right? Okay, so that patient is at risk of what? One, Pseudomonas. How do you cover that if you're only on azithromycin? You have to add what? Cefepime with azithromycin, or just, let's do this. Shift it around. Put only cefepime, which covers Pseudomonas, and you get rid of the azithromycin, right? Or you do Zosine, and that covers Pseudomonas. But what's another risk factor that a cerebral palsy patient in a nursing home has? MRSA. So if you added your cefepime, add vanco. If you added your Zosine, add vanco. Do you understand? Okay. You are 72-year-old and you come with pneumonia, regardless of your comorbidity, I don't care. You need to be on Levaquin. You need to be on Levaquin. But you're 72 that has prostate cancer. Forget about the nursing home, you have prostate cancer. If you have prostate cancer, that is an immunosuppressive condition, isn't it? Yes or no? Even more if you're in chemo or radiation therapy. Forget about nursing homes or traveling outside the country or being hospitalized, you're immunocompromised. So you have Levaquin on board. What would I want to cover in an immunocompromised patient? Pseudomonas and MRSA at the vanco. Okay? So now you're allergic to penicillin. You can't have penicillin at all. Well, you are that 22-year-old, forget about the cerebral palsy. I am 22, I have no comorbidity other than asthma, and that doesn't put me at risk of anything. So you have azithromycin on board already, right? So there's no need to worry about allergies. So far, so good? Okay. But the 22-year-old that has cerebral palsy and lives in a nursing home, I can't add rosethin because you had an anaphylactic shock to penicillin. So what do you add me on? Well, you have the choice of vanco because you live in a nursing home and you have the problems of Pseudomonas or MRSA, Levaquin. Go to the next step of the comorbidities. Levaquin and vanco. I can't give you Zosine, right? I can't give you rosethin. I cannot give you azithromycin because you have comorbidities and you live in a nursing home. Yes or no? But I can give you Levaquin. What else can I give you if I don't want to give you Levaquin with vanco in combination? Doxy, Clinda. Those are the choices. Okay? So we talked about encephalitis already. We talked about sinusitis and the signs and symptoms, so now we're speeding up. How do you treat sinusitis? Amoxicillin. You're not getting better. Amoxicillin clavulate. And the guideline is coming. Okay? So let's start with viral. You have rhinosinusitis. Again, remember, the most common etiology is viral. What are you going to do there? You can't put an antiviral. Symptom management. Vaporizations, nasal wash, right? The fever, treat the fever, plenty of fluid, right? You can even apply facial packs, warm on your face and treat the symptoms. That's for viral sinusitis or rhinosinusitis. As you can see, saline irrigation, you have different. Try to get rid of, which is a question of over and over, of Sudafed, or for example, the Afrin, thank you. Afrin that has a lot of vasopressors. That increases your blood pressure. Even though the absorption is minimal, can increase your blood pressure, but in addition to that, it creates dependency. Why? Because it vasoconstricts, but then when it vasodilates again, you get more nasal congestion, okay? So this tends to be, it's important for practice to educate the patient because they're gonna be using aspirin for life if you do not educate them properly, but also the fact that produces high blood pressure, okay? And of course, I have to avoid irritants. You have here the first line of treatment, which is amoxicillin, unless the patient becomes really bad, in the sense of severe facial pain, fever doesn't improve after 72 hours. It's when you add amoxicillin clavulanate, okay? Even though you have the choice of Bactrim DS, if the patient is allergic to penicillin, that is not the first line. Azithromycin is the first line as a choice. If you have a patient with an anaphylactic reaction.
Okay, so augmenting.
Exactly. So then, again, amoxicillin alone is your first line. After 72 hours, the patient is not improving. What will you do? Add clavulanate, which is augmented. Amoxicillin clavulanate, which is augmented. You would see in the table, if you have an allergic reaction, but it's a non-type 1, it's okay to use cephalosporin, first or second generation, at your choice. But if your allergic reaction is anaphylaxis, you cannot use cephalosporins. What would you use? Azithromycin is the first line. But what else can you do? You could do Doxy, you could do Clinda. It's not wrong. Okay, you could do Bactrim DS, but it's never the first line. You have it right here. See? Non-type 1, first generation, Ceftinir, Opnicef, or second, cefuroxime, Cefti. You can choose any. I'm not going to ask you like specific, okay? It's going to be like real noticeable in your question choices, okay? And a type 1, which is you had angioedema, patient couldn't breathe, you cannot use cephalosporin, you have to use azithromycin or clarithromycin. Macrolide family is your first line of treatment. Guys, this is pharmacology. Okay? You have other possibilities. And again, another question for board. What do we do in clinical practice for every patient that we believe they have sinusitis? CT of the sinuses. Wrong. By guideline. Sinusitis is diagnosed by clinical presentation and by transillumination. There's no need to do a CT scan of the sinuses unless the patient does not improve after 3 to 5 days, okay? So as you can see, of course, patient has most likely the comorbidity of an allergic, asthmatic, septal deviation, and prior upper respiratory infections in the past. And you diagnose sinusitis, what would be your first choice? Amoxicillin. The patient doesn't get better, it's not here, but the patient doesn't get better, amoxicillin clavulanate, right? So basically you treat normally for 10 to 14 days, but if at the 3rd day the patient doesn't get better, it's when you add amoxicillin clavulanate, second line, okay? Now, again, you're allergic to penicillin, but it's not a type 1, it's only a rash. You need to ask your patient. It's not allergic to penicillin, that's it. What happened? Oh, I don't know. My mother told me that. But when my mother told me that, that means it's not relevant. Because I had an anaphylactic reaction in Cuba, which I don't remember because I was little. And my mother told me, you better make sure that you don't get a penicillin in your life because you can die. And you can die, that means die. That means anaphylaxis, okay? So I do not touch it, not even when I was a nurse. with gloves, believe it or not, with gloves, one day, drop in my skin, and I had a major reaction that I had to go down to the ER quickly to have epi, okay? Just by touching my skin, okay? That's when I believed her. So again, you have an allergic reaction type 1, your best choice is what? Macrolide antibiotics. But what else can you do? Well, you can do Clinda, you could do Doxy, you could do fluoroquinolones, you could do Bactrim, which are never the first line, okay? Now, the patient have gone through 10 days, 14 days of antibiotic and is not improving. That's when the guideline says do CT of the sinuses and refer to the ENT doctor.
10 days?
Yes. Again, do not answer based on your clinical practice.
Poor patient though. What is
I will ask it myself, but you can write that in your exam. Okay? So, Grace, 35-year-old female, ER, 3 days of fever, worsening sore throat, odinophagia, which is painful to swallow, no cough. She's sitting up on the examining table, leaning forward with her mouth slightly open, has a cough of saliva, meaning that she can't swallow saliva. It's really bad, right? Her voice is muffled, and she has stridor. Vital signs are tachycardic, temperature 102. Her mouth is fully open, and her posterior pharynx is red and swollen. No exudates or tonsillar enlargement. Now, but when you can swallow and you have your mouth open and you have stridor, that means airway obstruction. Okay? By epiglottitis, laryngitis, or an abscess. Something is colluding. That's the reason why we did this CT neck on this lady, even though she had no shortness of breath, no stridor, no mouth open, no drooling, but it was so out of the range of the ordinary that we had to rule out a possible abscess, okay? So we went through acute pharyngitis, right? So basically, how do you diagnose? You do a rapid strep. And if it's negative, what happens? You rule out? Depending on your clinical suspiciousness, right? Because if the patient has all the clinical signs and symptoms, you have to do strep cultures and treat the patient empirically. All right? So how do you treat the patient? Exactly the same. There's a criteria of when to just forget about it and you don't have to pursue cultures, or you must pursue cultures, or when you don't even bother about cultures and go straight to the antibodies, okay? So that criteria is called Center's criteria, which if you remember, my patient had no cough. So that point is out, right? Swelling and tender cervical nodes. So there was no lymphadenopathy, right? Do you remember that? So that's out. The temperature was higher than 100, so 1 point. The patient had no exudates. Do you remember?
Why did you put a swallow?
Well, she couldn't swallow, so 3. And her age, I don't remember her age. 35, so she's in this range, so only 3. So she will be here. Okay? So that means that depending on the points, if you have 0 to 1 point, let's start with the 0 first. If you have 0 point, that means that if the rapid strep is negative, you do not have strep. Do you follow? Okay. But if you have 1, just a particular fever and maybe sore throat, which is not here labeled, it's just the swelling, the lymphadenopathy, what's labeled here. But if you come with fever, which is at 1 point, and already sore throat, which is still 1 point, it's at the discretion of the practitioner to have a strep culture after a negative rapid strep. That's why it says option. Okay? Then 1. 2, for sure, from 2 on, for sure, if you have a rapid strep negative, with the clinical signs and symptoms of strep and more than 2 points in the criteria of center for pharyngitis, you must do pharyngeal cultures and treat empirically anyways, okay? As you can see here, not testing, no antibiotic, from 0, okay? And 4 or more, you don't even need the cultures, because if you already have lymphadenopathy and swelling of the posterior pharynx and exudates, and the patient is in the teenagers or pediatric population, which is the highest, most common population, already you have 4 points, and at that time, forget about cultures, forget about rapid strep if it's negative. You treat, and you can prove it with the anti-streptolysin antibody. You understand? This is the same thing explained in the paragraph. And how do you best treat? We already know that you treat beta strep exactly the same way, okay? So now, these patients can have a complication, multiple complications. Beta strep, remember that can produce not only peritonsillar abscesses, liquid angina, can also produce rheumatic fever, right? Which is a complication of that the rheumatic fever itself can branch out and produce carditis, arthralgias, multiple nodules, right? Valvulopathies, etc. Okay? So let's start first with one of the complications of strep throat, which is no more than either having an abscess in the posterior pharynx or just a major purulent accumulation of discharge at the level of the floor of the mouth, okay? Between the palatine and the sublingual gland, all right? So patients basically come in with the liquid angina. They come in with not only the sore throat and the fever, but they also have a swollen neck and or swelling of the floor of the mouth. You're gonna see a picture there. But they have a particular voice. They have a Mickey Mouse voice. Have you heard the cartoons talking like Mickey Mouse? They call muffled voice, but I have heard it in my life in front of me with the female patient that I saw in Kendall. They actually have a Mickey Mouse voice.
Like a high pitch?
They can't talk louder than that. Okay? It's a high-pitched tone. And of course, they can't swallow. And sometimes it's so big that they tend to have upper-airway obstruction, like striders and odinophagia. They can't swallow properly. They can't breathe properly. And they have also mouth open and drooling the same way as epiglottitis. So how do you best treat having an abscess anywhere in your body? You have to drain it. You have to drain. Now, of course, it's not going to be you, right? It's going to be an ENT who's going to do that in a secure airway to a patient in the OR. And of course, empiric antibiotic treatment. How are you going to treat liquid angina? Tell me, how do you treat an abscess?
Well, you have to.
Even though it's in the upper airway, remember, any abscess has the possibility of what? Anaerobic and pseudomonas, right? It's an abscess, it's a purulent discharge. So even though it's in your upper airway, how are you going to best treat? Amoxicillin will do it? No. So again, if you choose amoxicillin, let's combine with what? With your tazobactam, which is your Unicin, right? And if you want to add the Clinta to it for anaerobic, fine. Other combination. Tell me other possible combination. That's penicillin. Let's choose cephalosporin. Cefepime, Maxipine, or Rosefin is fine. How are you going to cover anaerobic? Clean that. Anaerobic. Don't confuse anaerobics with MRSA or Pseudomonas. Okay? How are you going to cover anaerobic? Remember, anaerobics are in your belly. Clinda or flagyl. So if you add the unacin plus flagyl or unacin plus Clinda, right? Right combination, that's penicillin. If you add cephalosporins, it could be your rocephin plus flagyl or rocephin plus Clinda, right? Now or again, your fourth generation cephalosporin, which is right, your cefepime, maxipine plus flagyl or plus Clinda. Tell me possible combination with allergic to penicillin. Type 1. You could do doxy plus Clinda or flagyl. What else can you do? Clarithromycin could do it the same as azithromycin, but it's very weak. Levaquin plus Clinda or levaquin plus flagyl. Yes, sir. Okay, that's the best combination. So you have it all there. What would be the difference then between Lewy angina and epiglottitis?
The epiglottitis, you have the airway obstruction, so you have to.
Epiglottitis is not bacterial.
Well,
It is pure.
Most commonly viral, but also it's associated with Haemophilus influenza, which is a bacterium. Most likely viral in pediatric patients.
Yeah.
But we can have epiglottitis in adulthood, and also Haemophilus influenza is involved in there. Rhinoviruses for kids, okay? So not only the actual pathogen, which is Lewy angina, again, most commonly the upper airway microflora, which is your strep, your Haemophilus influenza, or Moraxella catarrhalis, associated with possible anaerobic bacteria due to the abscess formation, right? How do you get an abscess in your mouth, guys? You either had an upper respiratory infection, most commonly pharyngitis, or what about dental procedures, right? Which is labeled there as well. So what else would epiglottitis have?
Thumbprint.
The thumbprint, okay? So if you look, normally this is the thumbprint sign.
in the X-ray.
Thumb. Okay? So as you can see here, this is your upper airway, okay? And posteriorly goes the esophagus. This is your larynx, right there. The epiglottis and your larynx. See the epiglottis? You see the triangle right there? And the larynx. When you have an obstruction, it looks like it's actually soft tissue edema that penetrates in the upper airway and collapses it. You see that the esophagus is occluded and the upper airway is also occluded. So the patient cannot swallow or breathe. So that's the reason why they have drooling, they can't swallow the saliva, and they can't breathe, they have stridor. Okay? So that's the thumbprint sign of epiglottitis. How are you going to treat this? The same treatment that we discussed in Lewy angina, but what about the airway? You intubate?
You need to. Well, you need to remove the obstruction. How are you gonna
Yeah, and it's actually contraindicated to do a pharyngeal examination. Occludes the airway even more. I'm not telling you that I have seen intubation in these patients. I have, but it has to be with the anesthesia. Why? Or if you have a gyroscope in your unit and you're brave enough to do it, you're able to visualize the airway clearly and past the 82. But you have to have the anesthesia team there with you in case you need an emergent tracheostomy. Okay? Retropharyngeal abscess is exactly the same as Lewy angina. The only difference is that the location. That one is in the actual pharynx, and the other one is at the floor of the mouth. Okay? But basically the patients would have exactly the same swelling, odidophagia, lymphadenopathy, dysphagia, difficult to swallow, and also to the point of occluding the entire airway and stridor. Okay? Now, sometimes if it's lower enough, they can also affect the cervical spine and produce osteomyelitis. So we went through, as I told you, in lumen angina, basically is at the floor of the mouth. You have a space in the floor of the mouth that I will show you the picture, that basically you have the sublingual gland and the submaxillary gland, and in that particular space is where a lot of purulent material accumulates and occludes the airway and the esophagus. This is basically the picture where you would have in this particular space, you would have the abscess formation. Okay? So the patients not only have the abscess in the floor of the mouth and a lot of erythema and swelling, but the area is not fluctuant like a normal abscess. If you have an abscess in your leg, for example, and you touch it, it will be kind of softy, and you can depress on it. Here it becomes so tense that the area is hard, like wood, okay? Really hard. And of course, you're not gonna drain that yourself from the outside. It has to be an ENT in the OR, okay? A lot of involvement of lymphadenopathies, look at that. So this area is super distended and tense, okay? And that child should be septic already. Do you see the redness and the tension? Okay? Now, as I told you, look for past medical history of upper airway infections, such as sinusitis, otitis, pharyngitis, or also dental work, or having an abscess in any of the molars. Like dental hygiene takes a lot of role in these diseases, okay? So the patient basically presents exactly as we described the case. They have fever, chills, malaise, pain at the level of the mouth, and drooling and dysphagia, and sometimes to the point of stridor, and even can migrate to the meninges and produce meningitis. So even though you can diagnose this clinically, you have to do a CT of the neck to be able to visualize the abscess, okay? And aspiration is the key, unless, surgeons are reluctant, or ENT are reluctant to take this patient to the OR. But remember, the penetrance of an antibiotic in an abscess is really, really low if you do not drain, okay? So we already went through the treatment of lumen angina and retropharyngeal abscess, right? So if you choose, for example, penicillin, again, and you choose ampicillin, give tazobactam, which is unacin, which is the combination of penicillin. Sosing is another choice, right? But remember, think about the possibilities of anaerobic bacteria here. So if you choose unacin, add Clinda or Flagyl. If you choose sosing, add Clinda or Flagyl, right?
Yes.
All the choices are cephalosporins. If you choose Rocephin, which is third generation, add Clinda or Flagyl. If you choose fourth generation, Maxipine, Clinda or Flagyl. You're allergic to penicillin, let's do Levaquin plus Clinda or Flagyl. Let's do Doxy plus Clinda or Flagyl. Those are your possible combinations. Another case. We have a 20-year-old man presented to his primary care with a 3-day history of swollen tonsils, sore throat, fever, chills, and rash. The rash is non-pruritic, started in the abdomen and spread to the chest and back, and then appears in the arms, legs, and face. No allergies or exposures to medication, and no history of similar rash. So that means that you're ruling out, which is the PowerPoint for next week, because it's too much for this week.
We have a test next week.
I know. After the test, you're gonna have 50 questions for free, and 50, well, if I can come up with 50 extra. But you're gonna have time to practice these questions, okay? So at least you're ruling out already possible causes of rash induced by medications or fever induced by medications. Okay, look at that. That's exactly how I saw my patient. It was purulent, discharge in the posterior pharynx. And look at those tonsils, they're already almost occluding the airway. And look at the fine rash. This is what I meant by, it looks like a heat rash, like a scarletiniform or morbilliform rash that you cannot really pinpoint what's going on. Like, it's like a sandpaper when you pass your hand through the skin. Never do that because it could be secondary syphilis and it's contagious. That is not contagious. This is not contagious. But when you press the skin, it blanches really easily because it's like a major erythema, like a major vasodilatory effect to the entire skin. Okay? So patients, sometimes the major differences between acute pharyngitis by itself versus, for example, scarlet fever, which is a complication of strep as well, highly prevalent in pediatric population, is the tongue that has like a strong, like a strawberry aspect. And when you tell the patient to stick the tongue out, you basically it looks like the papillas are so hypertrophic and the tongue is so red that it looks like a strawberry with the little, tiny little points. And those are the papillas, okay? And the patients have cervical lymphadenopathies. Now, if you have sore throat, if you have lymphadenopathy in your cervicals, in your neck, and you have fever, what else could it be? Could it be mononucleosis? That's the reason why we also test our patient for mono, right? The Epstein-Barr virus. The skin has diffuse blanching erythema with papules and in all the areas that we already went through, and also in the neck, but no petechia. So what do? We already went through this. For acute strep pharyngitis, if you're suspecting beta strep hemolytic, you have to do the rapid strep. And we went through the centers criteria that if you have a high clinical suspiciousness and you have 1 and above, you must do strep culture and treat the patient empirically, unless you have more than 4 in the criteria, which shouldn't even matter, even though we do the same for everybody in clinical practice. Okay? Now, this is I'm not talking about different diseases, it's just complications of strep. Okay? So remember, beta strep can be viewed, lumen angina, right? The peritonsillar abscesses and the pharyngeal abscesses. They can give you scarlet fever. They can also give you toxic shock syndrome, which our patient had, even though she was negative for beta strep, but she had a different source. Okay? So I'm not talking about aliens here. It's just complications of. And it can also give you rheumatic fever, which is another complication of beta strep, okay? So as you could see, the patient behaves exactly the same way as the patient with any strep, with exactly the same rash, as I told you, blanchable, full erythema, like a scarletiniform or morbilliform, or like a heat rash, okay? And basically, the patient difference is that besides the easily blanchable skin, you might also see that looks like the patient is scratching linear petechial damage. But you ask the patient, does it itch? And they tell you no. So why do you have that? Have you been scratching? And they say no. So those are, and those particular areas, line areas that look like scratch, when you put your finger on top, they do not blanch. That's the characteristic of petechia, okay? And you treat exactly the same way as the beta strep, no differences. Another complication of beta strep pharyngitis is acute rheumatic fever, okay? That you have to In order to avoid this, because it's a major complication, you have to properly identify better strep and treat accordingly. That's the reason why in clinical practice, we care less about the center criteria and we treat everybody because we are afraid of the possibility of acute rheumatic fever because of all the complications that will give you from carditis, nephritis, and rheumatoid problems, etc. Okay? So basically, again, it's a complication of better strep, clearly either by not treating the patient properly or non-patient compliance, or because the patient is autoimmune, immunocompromised, right? And goes straight to rheumatic fever. As you can see, the clinical manifestations coincide, because there's another criteria here called Jones criteria. It does coincide with the major Jones criteria. Having carditis, what would be carditis? Pericarditis and cardiomyopathies and valvulopathies. Polyarthritis, meaning that joint pain that can start monoarticular and can spread out through all the joints. Chorea, remember chorea? Think about chorea, about anatotosis, the involuntary, the same as Parkinson, okay? Patients with subcutaneous nodules that are non-painful, and erythema that not only starts being diffused, but then starts to fade in one area and appears in the other one. So it's called erythema marginatum or migratory, okay? So those are the major criteria, and the patients are diagnosed by having two major criteria or one major criteria and two minor criteria. I'm telling you, it's not there.
Oh, it's not here?
No, otherwise I will be reading. Right?
What's the name again?
John. Like John? No. Jones. Yes. John. John criteria. So what do you think will be the minor criteria? Fever. No, white count is not there. Fever, if you have the set rate elevated to more than 30, okay? If you have your another inflammatory marker, which is the CRP, more than 3. If you have in your EKG PR prolongation, even though it's not related to carditis or valvulopathies or myocarditis, but you have already an electrical conduction defect. So any type of AV block is in the minor criteria. So if you have two major, you're diagnosed. If you have one major and two minors, you're diagnosed. Jones criteria. And these are the major criteria: the carditis, polyarthritis, having chorea, subcutaneous nodule, or erythema marginatum. Okay? So here are the possibilities of having carditis. So you already know what is endocarditis, right? You already know how would the patient manifest with pericarditis or myocarditis. If you have a patient with any type of valvulopathy having the symptoms and also proved by an echocardiogram, okay? If a patient already has CHF, right or left, it's an indication of a major criteria for carditis, right? Having, remember, fever is minor, more than 38, okay? But arthralgias is a major criteria, all right? How will you manifest as chorea? Remember, involuntary atototic movements, all right? They're extrapyramidal. Having a first degree AV block, for example, would be a minor criteria. It's not a major criteria, even though it's included in carditis. So, how do you treat acute rheumatic fever? same way you treat better strep. If you choose amoxicillin or ampicillin, add the tazobactam, which is unacin plus Clinda or flagyl, right? If you add the Rocephin plus Clinda or flagyl, the same way we have gone through before. Now, that if the patient, depending on the severity, of course you have to treat the underlying problem of the complication of carditis, right? Because the polyarthritis is just pain related. You're just gonna treat pain, right? If you have a patient with chorea, those atherosclerotic involuntary movements can only be relieved by either Cogentin or Benadryl or levodopa carbidopa. Cogentin. Okay? If you have subcutaneous nodules, how are you going to treat that? You have to treat the strep for it to go away. If you have the erythema marginatum, you have to treat the strep for it to go away. So basically the major complications that these patients have, besides the extrapyramidal movement, would be the carditis. That is their major source of mortality, okay? But you treat the strep the same way, okay? Unless the patient, of course, is critically in the ICU, that's when you go to the higher level, which is your carbapenems plus Clinda or flagyl. Okay? What else can you do to diagnose this? As I said, you could do the antibodies. Remember that in the patient that we had in the hospital, we did the rapid strep negative, the cultures were negative, and we also did the anti-streptolithin O antibody to make sure that we weren't missing it, even though we were treating properly, right? And it was still negative. So, how many complications can this patient have? What happens is, again, the patients are exposed to beta hemolytic strep by an acute pharyngitis, and because they have an autoimmune condition, they develop immune complexes deposition, right? And damages what? Remember that type 3 hypersensitivity, what happens is that the immune complex is deposited at any other level. And in this case, we'll deposit at the level of the myocardium, in the spine, in the skin, in the synovial fluid, etc. Right? So basically that if it happens, for example, in the heart, you have all the signs and symptoms of cardiomyopathies. It could also happen at the level of the glomeruli, even though it's not part of the major criteria. It's not uncommon that these patients can have glomerulonephropathies. If you go back to 668, what was one of the major causes of acute glomerulonephropathies? Beta strep, right? So not only damages your joints and your heart, but also your kidneys. And that produces glomerulonephritis that you know glomerulonephritis have a triad, which is hypertension, proteinuria, and edema, okay? So what do you need to do to avoid all this? Recognize properly better strep and treat it, okay? And also educate the patient on the importance of being compliant, because otherwise the complications are really severe. We went through treatment already. Acute otitis media, I know it's long, but you have gone through all this. Nothing new for you. Acute otitis media, we already went through the signs and symptoms. How do we treat acute otitis media? Amoxicillin. Let's go through. Oh, how do you diagnose acute otitis media?
You have to, you're gonna see the swelling.
That's external. Right.
That's
How do you diagnose external? How do you diagnose acute otitis media?
Inspection.
Yes, what do you have there?
Bulging.
Bulging, okay? So, middle ear effusion and bulging of the tympanic membrane. Erythema by itself is non-specific. They always get you there.
and where it says, drainage?
Yeah, middle ear effusion. So you would see that the same as sinusitis, you have first choice amoxicillin. Unless the symptoms don't improve in 72 hours, some guidelines says 48 to 72, it doesn't really matter, it's the same thing, you're not improving. Then you are what? Amoxicillin clavulanate. Right? Let me jump here. This is what you had in pharmacology. So you have the symptoms of, I understand it says 2 years of age because, again, the guideline was never written based on adults, even though I had it. When I went to Punta Cana, I went through external and then it went internal. Middle. Yeah, I almost had mastoiditis. And I'm not immunocompromised. I think there's so many pee and poop in the pool that what made my ear immunocompromised. So basically, remember, if you get, guys, in board examination, if you get a question, what would be the best treatment or the first line treatment for acute otitis media? No, acute sinusitis or acute pharyngitis? Nothing! Nothing! Viral infection is the most common. That would be a general question. Now, if you see the signs and symptoms of bacterial infection, which is high degree fever, right, otalgia, or in the case of sinusitis, facial pain, etc., and the patient is not improving with symptomatic relief, then you start antibiotic treatment. That's why it says watch for waning event first. So if you have severe fever or otalgia, you have already tried amoxicillin first, but you're not improving and you're getting worse in symptoms. Amoxicillin clavulanate, right, which is augmenting. All right. So the patient responds, yes, continue. Right? 5 to 7 days. 3 or 4 weeks is the pediatric patient. If it doesn't improve, what will you do? ENT. And that's where I went. ENT. Now, these are the most common bacterial infections, which, again, why Pseudomonas in external? Pools. This is the swimmer ear, the most common cause. And unfortunately, 90% of people don't go outside to urinate. And 90% of people don't wash what they need to wash before going to the pool. And of course, E. coli is also there, right? How do you treat otitis externa? Topical. And actually, let me tell you, if you read the up-to-date, it's advised to do an ear lavage, even though it hurts. It's advised to do an ear lavage, a proper, professional ear lavage, before you put the drops, because if you have a lot of cerumen, the absorption will be diminished, okay? So, Genta is one of the choices, right? You could do also fluoroquinolones, which oxyfloxacin is one of the best choices, okay? It's external, so even though you have a mild absorption in your bloodstream and your cochlea, it's not, the Genta for 3 to 5 days is not gonna produce ototoxicity, okay? So now, we can go to the extreme. And what will be the extreme? Necrotizing otitis externa. How can you get necrosis and gangrene in your ear if you're not immunocompromised? Okay? So, and of course, anaerobic bacteria and Pseudomonas in this case is the most common, or any anaerobic bacteria. So the patient will actually look septic, okay? And the treatment for these patients is not going to be, if it's related to otitis externa, you're not going to put gentamicin or oxyfloxacin as a drop. This patient is septic. It requires IV antibiotic. Now you know that otitis, either media, okay, you would give amoxicillin, right? And if it doesn't get better, amoxicillin clavulanate. Yes or no?
Yes.
But now this patient has necrotizing otitis externa that needs to be hospitalized, not only for surgical debridement, but the patient is septic. What are you trying to give me? Let me ask you. If you choose amoxicillin, are you gonna leave it alone?
No.
What will you combine with? Yes, amoxicillin with the tazobactam, which is unison. Bring it up. Remember, you have penicillins alone and you have combination penicillin. What about Zosyn? Yes, but it's okay so far. It covers Pseudomonas, that combination. If you do not give me a combination, the only thing that you're covering is a strep and staph. Okay? So, if you choose cephalosporin, who covers Pseudomonas the best? Third and fourth. Ceftriaxone or maxipine, cefepime. But if you're immunocompromised, which any patient with necrotizing otitis externa has to be immunocompromised, who are you afraid of? Pseudomonas and MRSA. So if you already had your amoxicillin, tazobactam, which is unison, add me the vanco and you will cover everything. If you want the Rocephin, add the vanco, you will cover everything. Do you understand? If you have your maxipine, cefepime, add the vanco. Do you understand or not? Good. Glad. So this is the, look at how narrow is already the canal and you're pouring purely discharge. That membrane is already ruptured for sure.
That's a complication of necrotitis.
Yes. Now what else can you have that is, as you can see, from otitis externa, remember that from better strep, you can get mouth floor abscess, which is lumen angina, or you can also have posterior pharyngeal abscesses as well. But from the otitis externa or media, you can also get abscesses in your cervical area and lymphadenopathies. But the difference is that from better strep, it's strep. But from otitis, you have to also think about Pseudomonas. But the coverage is exactly the same with lumen angina. Didn't we say lumen angina, amoxicillin with tazobactam, and you add Clinda or Flagyl. You can add Vanco to cover Pseudomonas, right? But if you put Clinda and Flagyl, you're already covering Pseudomonas as well. So it's not wrong. Again, let me give you an algorithm here.
So why the other ones we're adding the clindamycin instead of removing?
Because you have abscess.
Ah,
Okay? If you don't have abscess, there's no need. No need to write. I always forget. Okay, so if you're thinking about MRSA, which are the patients at risk? Nursing homes, hospitalized patients, prisoners, recent treatment with antibiotics which are resistant, right? Okay, so the three major that cover is Vanco, daptomycin, or linezolid Cybox, and outpatient, Clinda. For anaerobic bacteria, so any ways that you believe that the patient has any type of anaerobic bacteria which live in your belly, or your urinary tract, or your prostate, for example. So from the belly down, the main coverage are Clinda and Flagyl. Which, if you have any of this anaerobic in your belly up, must be immunocompromised. They live in the belly down. If they appear in the belly up, you have to be immunocompromised. Then you have Pseudomonas. If you have Pseudomonas, if you choose a penicillin, you have to choose combination penicillin, which are Unacin or Sozin. If you choose cephalosporins to cover Pseudomonas, it has to be third generation, which is your Rosefin, or your cefepime maxipine. So from that little table, you choose, okay? So if you have a lupin abscess, okay, since you have also possibilities of anaerobic bacteria, that patient, I'm not telling you is coming from a nursing home, is coming from prison, is coming from hospitalized, resistant to antibiotic, travel outside the country, which are the patients that are high risk for MRSA, right? Or Pseudomonas. So if it's only anaerobic bacteria, that's the reason why in lupus angina, I only choose Clinda or Flagyl. But if the lupus angina patient is a traveler, it's an international visitor, then instead of Clinda, which is okay for MRSA, but it won't cover Pseudomonas. So I take out the clindamycin and Flagyl and I add my Vanco. With the Sozin, with the Unacin, with the Rosefin, etc. Okay, that's the difference. So this is exactly the same as lupus angina, but the source is the ear instead of the pharynx. Okay, so the same surgical treatment and exactly the same antibiotic coverage. I'm not going to cover necrotizing fasciitis because I did it last week. And the same picture. Now another process is called Fournier gangrene. Even though it could be present in pediatric patients and female, it's highly present in males. What can produce this? Well, first of all, trauma to the scrotums or the penis. And you have to understand that if you have a trauma to the perineum or the scrotums or the penis, you have to be immunocompromised to get up to this. Impossible, right? What about those patients hospitalized that they have a scrotal edema that develop an ulcer? If you're hospitalized for so much time to the point that you develop a scrotal ulcer, you can have Fournier gangrene. You're already immunocompromised to be so critically ill, and in highly broad spectrum antibiotic, right? And maybe steroids, you're already immunocompromised just because of the disease process that you're going through. Believe it or not, if any patient that is immunocompromised, and you will read like that in your book, it's not that I'm inventing it, masturbates too frequent, they can have Fournier gangrene. So if you're immunocompromised, take it easy. If you're immunocompromised. Okay? So as you can see, scroll edema, redness, to the point of ulcer, because it's a gangrene, this is going to be eventually a wet gangrene that not only anaerobic bacteria, but also gas-producing bacteria are colonizing the area, and gas. You feel subcutaneous gas, and it's highly fetid, the same as any gangrene in your extremity, right? So what do you think I have to do? Yeah, treatment. Yeah. And of course, you're gonna have all the signs and symptoms of sepsis, besides the fact that, of course, leukocytosis, elevation of lactate, renal failure, maybe liver failure, CK elevated, and of course the description that I already went through. Now, even though clinically you can see it in the initial stages, it will be impossible to differentiate between a pressure ulcer in the scrotum because of a major scleroedema versus the initiation of a gangrene, right? So you would have to do a CT or MRI of the pelvic area, and of course that includes the scrotums to be able to rule out the possibility of gangrene because the patient can even have up to the point of amputation, right, of the genitals. So the treatment is the key, all right? And how are you gonna treat this patient even though all the medications that we have gone through are appropriate? If you choose, for example, again, Rocephin, you have to, it's here, belly down. If you choose Rocephin, it's not wrong that you add Clinda, right? If you choose Sozin or Unacin, add Clinda or Flagyl, it's not wrong either. But because you have to be aggressive, have aggressive therapy on these patients, the same as toxic shock syndrome, many times you would see that we skip the first line and we go straight to the carbapenems and combination. So that's why you have carbapenem. If you have carbapenem here, it's imipenem, meropenem, ertapenem. There are three in the same classification, right? Or look at the beta-lactam or beta-lactamase combination. What is this? It's not a foreign name. It's Rocephin plus Clinda or Flagyl. This is Sozin plus Clinda or Flagyl. This is Unacin plus Clinda or Flagyl. Okay? So we can start with this, but you might see in clinical practice many times skipping the first line and going straight to carbapenem plus Clinda or Flagyl because of the likelihood that the patient can have an amputation of the genital area. It's a process. It's gangrene. Okay? Now, when do I add Vanco, Dapto, or Cybox? MRSA. Okay? And of course, the patient will be in shock. Fluid, and vasopressor therapy if it's needed. Now, try to avoid vasopressor therapy if it's not necessary because otherwise more vasoconstriction, less circulation to the scrotum, right? So if the patient is immunocompromised, give infusion of immunoglobulin, okay? In addition to that, what else can you do? You can put the patient in hyperbaric oxygenation to oxygenate the area. And the last, even though we went through it, well, the last of the streptococci and all that, even though we went through it, remember that I gave you a presentation of a real patient of toxic shock syndrome, right? So remember that if we have a criteria for toxic shock syndrome that we discussed, and it's going to be here again, but these patients, you're unable to find the source. Difficult finding the source. Highly common in patients that have tampon, menstrual tampon. But it could happen in any patients that have, for example, a minor trauma, patients that have, for example, even NSAIDs is an autoimmune reaction when you are in ibuprofen or Aleve. There's a prostaglandin immune reaction, and the patients can develop toxic shock syndrome. So there are many factors that can contribute to that. So again, it's also most commonly strep-associated infectious process that the patients would have, again, fever, myalgia. 10% only will present with vomiting, which our patients did. They have also this macular, papular, scarlet type of rash. The same way we gave the presentation of scalar fever, which is, again, is a complication of strep, toxic shock syndrome presents the way. So what would you think will be the difference between any septic shock and toxic shock syndrome? First, in septic shock, you are rapidly able to identify the source. The chest x-ray might have pneumonia, the urinalysis might have UTI, patients might have meningitis, patients might have burn, and now they're infected. Do you understand? In toxic shock syndrome, and also, for you to have deterioration of 3 or more organs, it has to be a cascade of events. You start first with septic shock, maybe you have acute kidney injury, but then you go to ileus, then you have liver function test abnormalities, you have coagulopathies, but in toxic shock syndrome, not only you can't find the source until you do eventually, but in addition to that, the deterioration of multiple organs is rapidly. And also they have the rash that these patients with any septic shock do not have. Okay? So hypotension refractory to fluid, which our patient had, erythematous rash, sometimes to the point, if you can't treat it and catch it on time, to the point of Steven-Johnson, like deformation of the skin. They can go into renal failure, they can go into ARDS, they can go into coagulopathies, they can go into liver dysfunction. Remember the criteria that you need to have at least 3 systems, okay? And depending on the source, you know, if the source was just laceration of the skin, they can go up to the point of necrotizing fasciitis, etc. So this is more or less a presentation, but I will skip it because we had a real case in clinical practice. You can read it. So as you see, no history of anything. So let's go through a differential diagnosis. If, for example, you have toxic shock syndrome related to a minor laceration of your skin, okay? The first thing that you have to rule out, again, is trauma, which the patient had, right? But never to the point of produced bone fractures or tendonitis or anything. What would be septic arthritis? How would the patient manifest with septic arthritis?
Pain in the joint.
First of all, is one joint, right? That patient has no history of trauma, and all of a sudden becomes swelling, erythematous, difficult to mobilize, right? And it will be warm, and the patients have signs and symptoms of infection in the CDC, right? Gout. How do you differentiate gout from having, for example, toxic shock syndrome related to trauma of a joint?
It's normally in the heart, you would do uric acid level before.
Now, uric acid level correlate with the pain and the amount of synovial crystals? No. And that's a question for board. Even though gout most commonly have uric acid elevated, you do not need to have an elevation of uric acid for you to have gout.
But then it would be pseudogout.
Yes, but you have the same symptoms. You have the same symptoms. Okay? And how do you best diagnose? It's not by having uric acid elevated, it's by aspiration of the synovial fluid and seeing the crystals in there. Okay? And how do you best treat gout? We know that acute event is colchicine, right? And allopurinol for maintenance. How do you differentiate psoriatic arthritis? We went through that skin process, right? So the patient has a history of psoriasis, right, in the skin. You have seen the plaques in the past, or they actually tell you that they have a history of psoriasis. And now the patients have basically joint pain, okay?
And they will still have usually dermatological.
Yeah, that's what I said. They have a history of the plaque.
So they'll still have.
Rheumatoid arthritis, the difference with septic arthritis. Remember, this is monoarticular, only one joint, and this is polyarticular. Systemic, right? You have AMA-RA, and we're gonna go through the antibodies, even though many of you maybe already had it, but I could finish in 668. And you have the antibody proper for that, which septic arthritis only would have ESR and CRP elevated, and so on, okay? So we went through it already. So CRP and CR rate are only inflammatory markers, sensitive, but not specific to anything. And that's why I have a question mark for uric acid, because it's not actually necessary to have it elevated for you to have gout, okay? So how do you best diagnose gout or even septic arthritis? Arthrocentesis. Now, nobody's gonna stick a needle when you have infection in your joint. but actually it's the best way, okay? So that's the most specific diagnosis. You see the synovial crystals in gout, you see granulocytes, leukocytes, and septic arthritis, okay? And of course, you're gonna do blood cultures in the septic arthritis patient. How do you best treat septic arthritis? Antibiotic. It's deep in the joint, it's not in the skin.
Same,
So let's choose, since you're very close to the skin, right? It could be strep and staph, right?
Yeah.
So if you choose amoxicillin, are you gonna stay like that? No, you're gonna see. If you choose penicillin again, you have to combine Sosin. In this particular case, you don't need to combine with Clinda or Flagyl because it's in your joints. Okay, it's not in the anaerobic area. It's just deep, but close to the dermis, right? It's just in the joints. If you choose cephalosporin, prosapine, or maxipine, cefepime, that will be enough. Are you allergic to penicillin? Clinda, Doxy, Levaquin, but Levaquin in this case is not the best choice. You already have a joint affected. Okay? So we went through it. So in addition to that, of course, when you have arthrocentesis, which again, in clinical practice, we don't see it being done because no practitioner is gonna stick a needle in there, they're just afraid. But the most reliable diagnosis for septic arthritis as well as gout is arthrocentesis. Get the fluid, aspirate, and send it to analyze. That you will see a lot of leukocytes, more than 50,000, sometimes based on granulocytes, which are neutrophils. And in gout, you will see the synovial crystals. Now, always ruled out in a young patient gonorrhea, because gonorrhea can also give you migratory arthritis, like polyarthritis. Okay? Of course, mostly in women, because the male, they have this evident purulent discharge going through the external meatus, and we tend to have it hidden inside, in the cervix or vagina, so we don't get a clear clinical indicators as much as the male, okay? The best way, even though the first initial diagnostic test for any type of arthritis, psoriatic, gout, septic, trauma, you do an x-ray, that's the initial. The most reliable diagnostic test would be, again, arthrocentesis for gout and septic arthritis. And imaging-wise, the most reliable diagnostic test will be an MRI, because not only you will be able to see the joint with signs and symptoms of sepsis, which is there's granulation tissue, there's basically lytic factors at the level of the head of, or the patella, depending on where you have the septic arthritis. But in addition to that, you're already ruling out osteomyelitis in there. Okay? So we went through the treatment. When do I add Vanco? Remember, you can have, it's very close to the skin, so if you have septic arthritis, strep and staph, when do I add Vanco? Well, you were in the hospital for some other reason, maybe you fell, and you don't have trauma, but you have a swelling knee that has a lot of patellar synovial fluid extravasation, and now becomes red and you start having fever, blah, 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 but you were in the hospital. That's the possibility of MRSA, right? You were hospitalized. You were not hospitalized, but you had recent treatment with antibiotic for another reason, and now you have septic arthritis. You have the possibility of resistant, multi-drug resistant organism. You have to cover with Vanco. Or this patient has septic arthritis, again, traveling outside the country, living in nursing homes, etc. Okay, so that's when you cover with Vanco. Otherwise, it's not necessary. Okay, what time is it?
4:23.
We have to be in the lab. So let's. Is it too much left over?